So I'm going to talk a little bit about the increasing role of clinical engineering within interoperability and electronic documentation and IT and security and all of those different things that have been touched on. Like Sam mentioned, I also work at Yale New Haven Health System in Connecticut. I'm also a senior manager, similar to Samantha. I previously was a clinical systems engineer at Yale for about 10 years before coming into this role last year. I got my bachelor's and master's degrees in biomedical and clinical engineering from UConn and a healthcare informatics degree from Sacred Heart a little bit later on. But I'm going to talk about sort of how we, developed our program at Yale and sort of where it started and how it grew into what it is today. When I first started, actually before I started in 2011, both IT and clinical engineering were separated across our health system, and like each hospital had their own groups. But in 2009, as Elliot mentioned, we had the High Tech Act that was passed that created a lot of incentivization for meaningful use of electronic health records. So there was reimbursement from our Medicare and Medicaid in the U.S. That really pushed for improved quality and efficiency and maintaining privacy and security of the information while expanding the capabilities of the medical record. And so at Yale, at the very beginning, we had all these different medical records, all these different systems that were being used. And IT leadership from the different hospitals were brought together, and they decided to go forward with Epic as a consolidated health system EMR. And so in 2010, they started, combining all the different IT groups into a consolidated system level support system, so that they could plan out that Epic deployment. At that point, CE was still siloed and not really involved, but they did create an IT team that at the time they called the BMDI team, Biomedical Device Integration, and that was when I started in 2011. And our goal was really just to make it so that the data from the anesthesia machines, all the different monitoring in the ICU, step down, emergency rooms, procedural, respiratory, ventilation, all that stuff, to make it so that we could send that data into Epic. We were very successful at that, but through the process of our first go live at Greenwich Hospital, it really was obvious that we were doing a lot more than just that. And they also found that there was a lot to be gained from the consolidation that they just went through for IT and doing the same thing for clinical engineering. So the next year in 2013, they did the same thing for CE, but they brought it under IT, hired a director, and brought the team that was previously just part of IT under clinical engineering. We now call that team the CE integrations team. And since then, we've just continued to expand what we are, involved with over the years. We started with just the integration of equipment, mounting our devices on different pieces of equipment to pull the data into the medical record. The one on the right there is our Mobile Vitals solution, which was more than just collecting data, but actually like putting out a piece of equipment that receives patient information from the medical record, and the users have to log into it. And when they send the data back into the medical record, it's already validated based on the security checks that happen. And since our team were the ones who were deploying it, we were also very heavily involved in each of those aspects of the application. So while we were part of clinical engineering, our team was also very much an IT team. And we were sort of the people who communicated between IT and clinical engineering. We did a lot of translating between the two teams because there really is, as the other presenters have mentioned, maybe some misunderstanding of the two sides. And our team in the middle was very important because we could sort of understand both. And, as we continue to move on through our medical device integration, we were able to add so many positive things for the medical and clinical users, patient positive identification, the accuracy of the data was better, the documentation time went down, and over time we've seen just an increase in the number of in the utilization of all of those devices. You can see in 2015 when we first deployed, it just has steadily grown with a big dip for COVID, but continue to grow, and our team is continuing to support that and expand it as it's going out. And we have a lot of involvement from the clinical engineering proper that Samantha mentioned, because they're out there supporting the vital signs machines, and we do a lot of training so that they understand the integration tools and they can do a lot of that work as well, and they don't always have to call our team or IT or desktop to help with those things. And as our team continued to grow in our responsibilities, we added fetal monitoring to be able to send waveforms to a central location so they could view, and similarly had EDT to get the patient information and send results back into the EMR, and then the EMR data also coming back. So it was another sort of example of our clinical engineering team needing to be pretty heavily involved in communicating with our EMR support team from Epic and IT to be able to make sure all that communication goes through properly, and that whenever there's issues, we're the ones who are called first, because like was mentioned, sometimes the IT teams don't always understand the importance of a monitor being down or something unplugged, it really impacting the ability of the clinical users to support their patients. We also we're part of the implementation of our tele-ICU, because a lot of the waveform data that comes off of the physiological monitors, we had to deploy a few different ways of collecting and sending that data so it could be visualized at our bunker in a central location. So they can do, we pretty much just do overnight monitoring right now, but we have the capability of expanding that over time to do 24/7 monitoring of all of our ICU patients to support the clinical staff who are on site. And the implementation of the cameras and the integration with Epic and the waveform data specifically was a new feature that a lot of the IT folks don't understand how that physiological data, where it really comes from and how it's connecting. So we really needed to work very closely with the technicians who support the equipment, and they are all very knowledgeable on some of the connections, because they have had to be very involved with all these projects. We also send a lot of our alarms to different locations. We in our neonatal ICU in New Haven, we connected our physiological monitoring, our nurse call, our ventilators to all send alerts to mobile phones. This was another one where IT was very involved, but our team, as that intermediary, really needed to coordinate with the clinical users on, what alarms do they want to send, what's the importance of the alarm, who does it need to go to. It was a very clinical discussion that needed the understanding of what the actual alarm means. And so our team was very heavily involved with that kind of initiative as well. We also did, just last year, went live with infusion pump interop. Again, just trying to make the lives of the clinical users that much easier. But when you have 5,000 infusion pumps in your health system and you need to touch every one of them in order to set up the integration and get the software updates on them before they go live, you really need a team effort. So all of our biomedical technicians and the C integrations team and a lot of the people from the vendor were there to help with making sure that this was a success. And since that went live a little over 6 months ago, a lot of the clinicians are being able to program their pumps using a barcode scanner and just pushing a button to confirm that it's correct on the pump. Really cuts down on the programming errors, really simplifies the documentation in the record, making their, the time spent on this decreases a lot. So it makes their whole process a lot simpler. We also send a lot of our alarm data into a central repository, and we use that to support different research initiatives, making alarm management decisions, whether we want to change the settings for certain alarms so that they don't trigger until it decreases to below a certain number for SpO2 alarms. We're working right now on trying to create better dashboards like the one I'm showing here that staff can actually interact with on a day-to-day basis to make some better clinical decision based on what they're actually seeing live on the floor. So our team's also very involved with that. Clinical engineering needs to be the ones making those changes a lot of the times if we're doing settings changes. So it's very important that we're involved in the process. And then as this team continued to grow and be more and more involved with both clinical engineering and IT aspects of our environment, we really did start to see the need for security. In 2018, there was a report by the Ponemon Institute where most IT budgets of healthcare systems across the or of non-healthcare, but other organizations spend about 4 to 7% of their healthcare spent 4 to 7% of their budgets on cybersecurity, where other industries spent 10 to 14. So it's obvious that we're not spending as much as we really should, or at least weren't. We'll probably increase that number a little bit due to all of the different things that have happened in the last 4 years. But it really shows when you look at how much you actually lose if there is a breach. It's much more costly for healthcare, so we really should be spending more to prevent, so that we don't have to spend as much if it ends up happening. Really is a risk-reward analysis that is very important. The other piece to that is that it takes a long time sometimes for these data breaches to be discovered, and if you can catch them faster and alleviate the concerns faster, you have a much higher chance of saving a lot of money. And that's one of the ways that we use this kind of information to look to find a vendor that we could partner with to do our security initiatives. We have a very large hospital, 2,500 beds, over 65,000 medical devices, 700 different vendors. It's a lot of information traveling across our network. So we put together a team of our Office of Information Security, clinical engineering, and our network team to really try to look towards our, what do we need to do in order to protect ourselves? So the first step was to find out what's actually on our network, assess that risk. Once we were able to actually know what's there, we could start to prevent further vulnerability. So we put this team together, and we ended up going with a Medigate was the vendor that we went with, and we do passive monitoring on our network with sensors all over our network. And this part was more of the network team, but we needed to be involved with the decision to go with this vendor, because once we got all those sensors out there and discovered 30,000 different medical devices, we needed to be able to get the alerts and respond to them. There's things like this where this is a network map showing a whole bunch of external IPs being communicated to by a device. And it was a device that wasn't supposed to be. So we were able to validate that wasn't correct, and put through with the collaboration with our network team firewall rules to prevent that from going through. It also gave us a better view into all of our different out-of-support Windows versions so that we could start to prioritize capital decision-making for replacing some of that equipment. It also allowed us to be able to merge some of this information with just recalls. So the system would flag things and trigger when there's recalls on equipment on our network, and identify things that, you know, an alert just comes out and we don't know what's actually impacted by that a vulnerability yet. A system like this was able to help us to flag those and be able to respond more quickly to things like Bluekeep and Log4j. And there's a lot of little things too. You know, all these seem to be very IT based, but when they're on all of your medical equipment, unencrypted PHI, default passwords, plain text transmission, it's all, you know, IT speak. But if we want to fix these vulnerabilities and lessen our concern over them, we really need to have clinical engineering be involved, because a lot of times in order to change passwords, you need to get into the medical devices, you know, support modes and call in the vendor to do the work. So it really is important that clinical engineering is involved. And I think I'm running late on my time, so I'm not going to keep going so we can get to some questions.